Hello, everyone. I want to welcome our Health for the World International Grand Rounds speaker today. We are delighted to welcome Dr. Purvi Parwani. Dr. Purvi Parwani is an assistant professor of medicine, cardiology at Loma University. She earned her medical degree from Gujarat University, Ahmedabad, India. She received residency training in internal medicine from University of Connecticut Cardiology at University of Oklahoma and also advanced training in cardiac imaging from the University of California, San Francisco. Dr. Parwani is passionate about cardiac imaging, particularly cardiac MRI and echocardiography. She is the only early career representative on board of Society of Cardiac MR. Her imaging interests include inherited cardiomyopathy, including HCM and restrictive cardiomyopathy, and also women's cardiovascular disease. Dr. Parwani's topic today is restrictive cardiomyopathy. Dr. Parwani, thank you so much for doing this for us, and you can start whenever you're ready.
Thank you for that warm introduction. I'm going to share my slide and see if I can.
I can already see greetings from Mexico, and Dr. Parwani is amazing in the chat box.
Thank you, guys. Let's see if I can share my screen. Are you able to see my screen?
Yes, very nice.
Beautiful. Okay. Great. So today we are going to speaking about restrictive cardiomyopathy, and I've purposefully fixed the topic on one only, which is cardiac amyloidosis, which is the predominant reason why patients get restrictive cardiomyopathy, or at least that's the one where the understanding of diagnosis is very important, given now that we have a treatment option available, particularly for the TTR. So I have no disclosures pertaining to this topic. So let's start with a case. So we have a 50-year-old African-American woman who does not have any past medical history. She presents with 1 week history of shortness of breath, lower extremity edema, and increasing abdominal girth. She also has 15-pound weight loss over the last 6 months and a decrease in appetite. As I said, she doesn't have much past medical history. She rarely smokes and drinks. And she has colon cancer in the cyst. And this is her examination. And you can see that she just had some decreased air entry bilaterally. She has some ascites, pedal edema, 3+, so quite a bit of pedal edema. On her labs in emergency room, she has increased pro-BNP. So it's 332, which is increased. Her troponin is mildly elevated, very trace elevation in the troponin. And then she also has CBC of 10,000. The chemistry is normal. However, the urine has 3+ protein. Her LFTs, TFTs, and RFTs are within normal limit. And the EKG shows normal sinus rhythm. So we'll start with echocardiogram. I know a lot of you were interested in echocardiogram, and it's truly a modality that's available across the world. So let's talk about it, and we'll come to cardiac MRI and other imaging modalities later in the topic. But basically, this is her, what we call the parasternal long axis image. So this is the left ventricle, this is the right ventricle, this is the left atrium, this is the aortic valve, and here, right here is would be the aorta. So you can right away see that for a woman in her 50s and without any past medical history, she clearly has some LVH. The muscle is thickened and it does appear a bit bright. So let's go to the other images. So this is her short axis image. And again, you can see similar kind of brightness and LVH in this LV. So this is her apical image. So again, on the apical images, you are able to demonstrate that she has thickness of both the left ventricle as well as the right ventricle. In addition, you can see that her atria are also dilated. And there is quite a bit of a pattern to this ventricle. It's kind of like shimmering or sparkling, in other words. Let's go to the other. So this is the Doppler parameter. So on the left side, you have tissue Doppler. What we do is we put the pulse wave Doppler in the myocardial tissue, and we try to see how much it's moving relative to the myocardium. And it gives us a idea of, how the cardiac tissue may be. So here you can see that the medial E prime velocity is 6, which is reduced. And then this is her pulse wave Doppler mitral inflow. And you can again see that this looks, almost normal mitral inflow, but when you combine it with this tissue Doppler, which is quite abnormal, this becomes pseudo-normal mitral inflow. So if we combine the two, patient has diastolic dysfunction, at least grade 2, and would be more if she would get more volume overloaded. So she was, given she had florid heart failure examination, as well as other findings suggestive of heart failure, she was admitted to the hospital and was started on the furosemide or the Lasix drip. And she did have some testing, which we'll talk about at the end of the presentation. So you all have to stay till the end to know what exactly happened with this patient. So then the objectives of talk today are, we're going to know about what are the types of amyloidosis, what are the different phenotypes, and how do we diagnose these different phenotypes so that we can offer the patient correct treatment options. So the word amyloid was coined in 1932, quite a long ago, and was a German botanist who described amyloid to describe the waxy starches in the paint. And from there, how it intertwined into medicine is by Dr. Vercoe. So you all must have heard of the Vercoe's triad. And it's the same Rudolf Virchow who described the reaction of the tissue deposits with iodine and sulfuric acid. And this reaction was known as a marker for starch in the plants. And hence he came up with this name, amyl, which is starch, and oid, which is like. So amyloid means starch-like. And it was in 1922 where Congo rate staining was established, and then later on 1927 where apple green bifringence in a patient with Alzheimer's disease was first described. So we all throughout the medical school have learned these terms with amyloid, but I think my goal today is to give you kind of a clear idea. I think when I was a medical student and probably also internal medicine resident, I had some hazy idea of what amyloid can be, but I'm hoping that with today's talk, those ideas become clear, at least for the cardiac manifestation, and you are able to identify this disease pattern. So let's go through the video. So what it is basically every protein in the body has it needs some sort of folding, okay? And this folding has to happen in a proper pattern. So every amino acid, should go into the particular pattern to make the protein happen. When that does not happen, like in this case, this is called the unfolding, because the protein has not folded correctly. And that's when the unfolding happen, all that waste unfolded material gets accumulated everywhere in the body. And this process is known as amyloidosis, systemic amyloidosis. So we'll see another example of how it affects the light chain. So these are the, it'll go into the bone marrow, and, it's showing you the plasma cells where our immunoglobulins are formed, and the immunoglobulins are formed using the light chain. And why this example is because one type of amyloid involves the light chain. So again, it needs proper folding to make a light chain. But when the light chain is not folded correctly, the amino acids don't fit on it, and hence all this product, it gets accumulated on each other, and that's how people develop AL amyloidosis. Next we'll go to the overall types of amyloidosis. So what are the types of amyloidosis? So for our purpose for the talk, we'll just describe two main, but I'll give you a little background. So there are 27 precursor amyloid proteins. They have been identified, and every amyloid protein has individual amyloid disease. And there are 9 amyloid precursor protein that involves the heart, but there are only 3 that has significant cardiac involvement and common occurrence. So what are these proteins? So there is AL, which is immunoglobulin light chain, and this is the primary amyloid cardiomyopathy, and this happens, it can be primary AL amyloidosis, or it can happen in association with multiple myeloma, and the prevalence of cardiac involvement in AL amyloid is almost 50%. Then you have the second most common, which is ATTR. Now, ATTR is mutant transthyretin, wild type, or it can be wild type transthyretin, and we'll come to what it means in general terms. But in general, it can lead to a familial cardiomyopathy, or it can lead to a senile systemic cardiomyopathy. And these patients tend to have 30% of the cardiac involvement. And then you have the atrial type, and these would lead to isolated atrial amyloidosis. And this is what most of the patients older than 50 have. But I think the treatment option, the new treatment option is available for this type, the ATTR, and that's why it becomes very important. Unfortunately, AL patients have an extremely poor prognosis because of their association with multiple myeloma, or even the primary AL it can be because of the bone marrow, as I just showed, and hence, the treatment option and the prognosis is, limited. So let's talk about next about, sorry, it's the same type. I think I meant to bold this cardiac involvement, but remember that AL has 50% cardiac involvement, and ATTR, which is the familial, it has 30% cardiac involvement. But in clinical practice, all the cases of amyloidosis that I have seen are ATT senile type, not the familial type. So remember that's the wild type, this one, wild type transthyretin. And that's because, we do unfortunately see many patients more than 50 years old, and I'm in a blue zone, meaningly everyone where I am in Loma Linda lives more than 90 or 100 years old. So this is the only blue zone in United States. And because of that, we do see a lot of patients that are senile, and unfortunately some of them do have this type of amyloidosis. So AL, you can see that it's 9 cases per million, right? So it's quite uncommon, but think of it this way. It's as common as CML, the chronic myeloid leukemia, or Hodgkin's disease. So you can kind of put, you can kind of compare it relatively. Familial and senile are underdiagnosed, and particularly in the African American population. And so why that is, we'll talk in a minute. It's because of gene that is found in African American. So the AL amyloidosis is typically associated with the plasma cell disorders. And if there is more than 10% light chains, it's called the multiple myeloma. And it can lead to the multi-organ damage, and it has direct effect of the light chains on the myocardium, and that manifestation is what is known as cardiac amyloidosis, the AL cardiac amyloidosis. And as I already said, it has 50% cardiac involvement, but in 4% of cases, it would be isolated cardiac. So 4% or more would have isolated cardiac. And what that means is the patient predominantly present with the involvement of the heart. So next is transthyretin amyloid. So this is the one where we have the treatment available, and the FDA approved, I think, recently, and it's called tafamidis. That's the company name, but Vindenex or Vindemex is the name of the medication. And this one has more than 80 reported mutations. It can have variable organ involvement, neuropathy, cardiomyopathy, or both of them. Most common, the genetic mutation that is most common in the United States is called T60A. And the second most common, which is found in Portugal, Japan, Sweden, Brazil, where it is endemic, which is V30M. And then the treatment here is a liver transplant in the terminal cases. But as I said, that there's this option available to the elderly particularly. So TTR V1T22I mutation that is unique to the elderly people of the African descent, and it causes the cardiac amyloidosis without involving the organ, other organ, in the body. And this is the one, the variant is found in 4% of African Americans in general. So that is, quite a bit of population, and 23% of those with cardiac amyloidosis. So this is the one that we recognize the most, and we'll go into how to diagnose it and stuff in details. But basically, every time you see an African American patient with more than 50 years of age and disproportionate LVH, left ventricular hypertrophy, and you don't see that much hypertension, or they are not on many antihypertensive, that explains the hypertrophy. Obviously, last week we learned about HOCM, but the other thing that you always have to keep in mind, particularly with the echo features that I showed you, would be the cardiac amyloidosis. So this, I was telling you that senile type is the most common in the United States, and we have more males than females, and 90% of occurrence in more than 60 years of age. And it's seen quite commonly in patients older than 80, and it can cause involvement with the heart, it can cause carpal tunnel, it can cause pulmonary disease. The median survival of these patients is excellent compared to the AL amyloidosis. They live beyond 75 months, versus AL amyloidosis has 50% mortality in the first year. So coming next to the phenotype, so how would it show up in the body? What will you see, right? So there is varied manifestations in the entire body of amyloidosis. And I'm sorry. And here are some of the examples, right? So with the heart, it can cause cardiac amyloidosis. With the kidneys, it will cause nephrotic syndrome. It can lead to the vasculopathy of the blood vessels and can cause bleeding. With the nervous system, it can lead to, carpal tunnel. It can lead to orthostatic hypotension. The most common presentation that I see in these patients, it actually is orthostatic hypotension. Most of them will feel dizzy. They would have orthostatic symptoms, and then they will come with heart failure symptoms with florid, bilateral pleural effusions, pericardial effusions, and they'll be volume overloaded. You diurese them, you send them home, and they come back. So this is when, it's a very hard disease to fight. GI tract, it can cause macroglossia, which is the enlargement of the tongue. And I have a picture to show all of you. Endocrine, you have hypothyroidism. So it's important to check the thyroid hormone level. Lungs, you have the amyloidomas, which is basically kind of like the nodular infiltration of the lung. Skins, you can also have nodular deposits, and you can have lymphadenopathy. So now, important to remember that isolated cardiac amyloidosis can exist without any of this. So these all are not must for you, but if they are present, it will increase your suspicion when you see the patient for cardiac amyloidosis. So let's talk about physical examination. So what would these patients have, right? So you look for JVP, you look for orthostatic hypotension, which is standing and supine blood pressure. You're gonna listen to their cardiac exam. So do they have an extra heart sound? Do they have a TR murmur? Do they have a hepatomegaly? Most common finding is florid right-sided failure, which would mean that they will have 3+ edema, they would have pleural and pericardial effusions, and because of virtue of the way pathophysiology of the right ventricular failure works, you will have lots of hepatomegaly, and it can be tender in the cases of heart failure. And then they can have periorbital purpura. I have a picture of that. And then macroglossia, which is a big tongue. So this is that classic periorbital purpura, and this is from the Mayo Clinic website, and this is their enlarged tongue. So always examine the patients for presence of such findings, particularly your old senile patients. Seems like everyone has these findings, but this is very peculiar. The other thing that I have seen is that they often have bicep tendon rupture, and these are all board questions. So I think in US boards, I know that these physical examination cues would be presented to you in the form of the question, and then you have to pick up that these are all the cues for the amyloidosis and answer accordingly. So the cardiac manifestation, so what can it lead in the heart? So, the most common, obviously, as I already mentioned to you, is the right ventricular failure. So these are the patients who come with florid heart failure. No matter what you do, you make them feel better, you put them on lots of Lasix, and you send them out, and unless they are on the correct treatment, they'll come back and they have really poor quality of life. They are in hospital with repeated heart failure admissions. They typically don't have big vessel disease. So these are not the patients that will come with your STEMI and NSTEMI. They have small vessel disease because all this amyloid gets deposited in the vessel wall, and it will cause angina, it will cause purpura, it will cause jaw pain, so claudication of the jaw or claudication of the legs. It can involve the conduction system, and I have a slide on that, so wait for that. And as I said, it will lead to pericardial effusion, pleural effusion, but it rarely leads to the cardiac tamponade, and it can lead to syncope and sudden death. So NSTEMI, again, this is a study where, they took a patient, that presented with NSTEMI, and as I said, it's the intramural coronary vasculature that is affected. The clinical ischemic syndrome is, rather rare. It's 25%, and it may be the first manifestation of AL amyloidosis, but the cardiac cath would be, mostly negative. Now, when the conduction system, why this is important is because when you see the pictures of the imaging, it all makes sense. The way it involves the heart, it involves the basal portion more, and that's why you have high degree AV blocks. The sinus node disease is rare. And these patients are the ones that require pacemaker implantation commonly. But actually, the most common abnormality is in the His-Purkinje system. And this is again shown by many studies. And then the syncope, a lot of these patients would pass out and they'll have, complaints of syncope, but that's truly because of the inability to augment the cardiac output. And once the syncope sets in, unfortunately, the mortality is very high in the following next month because of the sudden cardiac death. And this sudden cardiac death is not a reason It's not caused by VT. So VT is an infrequent cause of syncope. It's more of an electromechanical dyssynchrony that leads to these, patients. They're basically, they are unable to augment the cardiac output, and that basically will lead to electromechanical dyssynchrony. So there's electrical signal, but there's no blood flow to go forward, and that's what causes the sudden cardiac death. And because unlike the HOCM patients that we saw how VT is, leads to a lot of manifestation, they have for sudden cardiac death, this patient population is completely on the other side. And hence these patients actually don't benefit from ICD. So remember that. Now, thrombus is a very common manifestation. And they basically have, different, the entire pathophysiology different, the milieu interior of the heart is affected, and they'll frequently have thrombus in the appendage. And that's why it's never cardiovert these patients when they come with atrial fibrillation without doing a TEE to rule out a thrombus, because a lot of them already have thrombus. And these are the causes why they would have thrombus. So they have low ejection fraction, they have advanced diastolic function, they have increased RV thickness, they have atrial fibrillation, they have, and because of all these causes, they will have thrombus in the heart. LA volume is not one of the things that contributes to the thrombus, which is in general population, left atrial volume or size is a very common determinant of if the patients would have thrombus. But in these patients, it's not, and it's quite interesting in that regard. So let's come to the next part, which is, I know all of you have been waiting, which is the diagnosis. So how do we diagnose these patients? So we looked at the different types, we looked at the manifestations, but what do we do to diagnose these patients? And, this is where I think most of the clinicians fail, and that's because we don't have much understanding of this disease. And then the diagnosis is, made in by doing specific testing, both invasive and the non-invasive. So the non-invasive testing, we're going to talk about obviously the EKG, echo, the nuclear, and the MRI, and the blood test, which particularly is helpful with the AL type of amyloidosis, is the free light chain issue, and the serum and urine immunofixation. So remember, SPEP and UPEP has minimal role in these cases. If it is positive, that's great, but it's negative, it does not exclude. And that is, I think, probably most of you have the understanding that SPEP and UPEP somehow are the diagnostic choices. At least our residents here, that's what they think when we ask them the questions. But remember, that's not the only testing you have available. And obviously there is invasive testing, endomyocardial biopsy. And I'll tell you why the whole thought process has changed. When we look at the EKG, one of the things that people talk about is, if it is low voltage EKG, that is amyloidosis, right? So, unfortunately, the low voltage EKG that we all know, it's only described in less than 50% of the patients in the clinical study. So it's not a must. Again, remember, we try to put patients in the boxes, and unfortunately, patients don't fit any boxes, patients don't fit any textbook. They come in between. And try to recognize that, and don't put the patient in boxes just because they don't meet XYZ criteria. You have to put everything together and solve the puzzle together. So this is what I just want you to remember, all of you to remember, that low voltage, if you don't have low voltage, that does not exclude amyloidosis. If the low voltage is there, it definitely helps you. It strengthens your diagnostic suspicion, but it does not help you if it is negative. And it's just a series where they showed what other phenomena, what other EKG manifestations existed with amyloidosis. When we look at the transthoracic echocardiogram, I showed you the patient with thickness of the interventricular septum and the posterior wall thickness. So when you combine, those three features in amyloid patients, interventricular thickness of more than 1.6, the posterior wall thickness of more than 1.6, and the low voltage was there in 56% of the patients in this amyloid group that has positive biopsy. So remember those. So basically, if you have low voltage with a septal thickness of this much, your diagnosis can be made with sensitivity of 72%, specificity of 91%. So when you have two features, you are increasing your diagnostic capability. But again, if it is not there, you cannot exclude it. So let's look at this. So 2D echo, what features you may have on 2D echo? Sorry. So we have already talked about this, but it's increased wall thickness. So you can see here, this is the myocardial wall. It's increased. And this myocardium, remember this picture in your memory. Okay, just stamp it. This is what we call as the sparkling pattern on the echocardiography. And this appearance, should make you think of amyloidosis. So along with that, what you will have is everything in the heart is thickened. So all the valves will be thickened. Your interatrial septum is thickened. Your atria are huge. And then, you have pericardial effusion, you have pulmonary hypertension, and you have severe impairment of basal strain. And I'll show you an example of what that means. But basically the apex may be coming in, but the base of the heart does not move much. So there is this difference from base to apex when it comes to the relative contractility of the heart. So remember that. This is the inflow pattern that I was showing you. So these patients would have pseudo-normal or the restrictive filling pattern. It's called restrictive cardiomyopathy for a reason. And what it is basically your pressure in the left atrium is so high that when that mitral valve opens, suddenly all the blood gushes into the left ventricle. And that, my friends, is that E wave. So that E wave would be high. And the A wave, which is the relative atrial contraction, will be small because your atria, are weak, and plus the contractility ability of the atria may be affected if you have atrial fibrillation patient. But this E wave is so big that the difference of the E to A, E by A, becomes more than 2. And this is what the restrictive filling pattern on the mitral inflow means. When we look at the tissue Doppler, again, I showed you that is basically when we put the pulse wave Doppler on the tissue and try to see the relative tissue motion compared to the rest of the myocardium. And these small little spikes, less than, look at this one. So this is less than 5 centimeters per second. So that should raise your suspicion for the restrictive pattern. When we look at the pulmonary veins, it's actually small systolic and the big diastolic, so this is the predominantly diastolic pattern on the pulmonary vein. So everything suggestive of the heart is not able to relax, and there is a component of the restriction. And this is, so restriction can be, from outside, which we know as constrictive pericarditis, or restriction can be because the myocardium is not able to relax. And that is what is your restrictive cardiomyopathy, predominant reason being the cardiac amyloid. So what is strain? So basically the strain is, it's again the torsion of the muscles, myocardial muscle, and you're trying to see, how this, the strain can identify different pathologies for you. So these 4 on the top are the examples of cardiac amyloidosis. So again, you can see, so the red is this red is the normal part, okay? So this is basically, we have cut the myocardium like a potato, and then we have demonstrated all the walls. So this is apical, this is mid, and this is basal. This is the septum and the RV. So again, apex, mid, basal. So you see that predominantly all the red dots in this case is focused on apex, or maybe the nearby areas of the apex. So this is what is known as bull eye pattern. So relative sparing of the apex, and that is what is seen predominantly with cardiac amyloidosis. This is the example of hypertrophic cardiomyopathy. And these are the examples from the aortic stenotic patients. So hypertrophic cardiomyopathy, you can see that it's, it's basically the septum that's affected, and everything else is red. That means everything else is okay. So with these different patterns, you're able to differentiate between the different pathologies. So this would be amyloid, which would be apical sparing, or the bull-eye pattern. There is a lot of research done on it. So now come to the nuclear imaging. So there are two bone agents that are available. So the technetium DPD is available in the Europe. In the United States, we use technetium pyrophosphate, PYP, also known as PYP. So let's see some examples. So this is a technetium DPD example. So basically what it is when patients have cardiac amyloidosis, the entire heart will shine up. When they don't, you see that this is just a bony uptake. Another example, so again, when there is cardiac amyloidosis, you have this uptake in the heart. And when you don't, you just have this bony uptake. So this is on the DPD. We'll see some PYP imaging. So basically, PYP, ATTR is the way PYP gets diagnosed. So ATTR is, remember, the transthyretin amyloid that I had shown you, that had two major types. One is familial, one is senile, or the wild type, also known as senile TTR. And the senile one is the most common that you'll see in the community. Basically PYP is the way we diagnose this senile amyloidosis. So let's see. So this is technetium PYP. So what we do is we basically try to look at the, so this is the raw images. So what you do is you take the bone, you look at the bone. So you can all probably see the sternum, and then you will see the you will see the heart to contralateral ratio. So these are two ROIs. So one is on the heart, another one is on the other side. And these are just on the raw images. I'm trying to explain to you how this works. So, you basically will try to take the ratio, and if the ratio, if the heart side is more than 1.5 of the other side, that's when you diagnose. So this is a example of so this A is negative, so you kind of don't see any other uptake anywhere else except in the bone. B is where you see the uptake on the heart. So you put one region on the heart, you put another region on the other side, and you try to take the ratio. And you can clearly see that this looks like a positive study, right? No one has to tell you anything. You can probably see it very clearly. So it's a 97% sensitive, 100% specific for the transthyretin type of amyloid. So these are two of my clinic patients. On the left side, you can see that this is a positive study. This patient is on treatment with tafamidis, and they are doing fortunately okay. And this is this is how we set up the the axial planes, try to see. So this is a negative study, and you can see that there's no involvement of the heart whatsoever. So you always wanna, when you have a clear-cut picture like this patient, you can see that heart, the whole heart is shining. There's no question about it. But believe me, there are so many in-between stages that keep coming that you need to have the axial images kind of to see whether it is the heart or the blood pool. And lots of, even the experienced people make mistake because it's difficult to see. So there are four types, four grades, and this is by SNAC, the American Society of Nuclear Cardiology. They have some practice points on amyloidosis, and try to check them out. I think it's free. You can just Google it and this will come up, and they're really good points. But basically, you're going to see the myocardial to contralateral run ratio uptake at 1 hour. You're going to, you draw those region of interest, and then you're going to see what's the the ratio, and you'll compare it with the bone uptake. So if there's no uptake and normal bone uptake, it's grade 0. If uptake is less than the rib uptake, it's grade 1. If it is equal to the rib uptake, it's grade 2. And if it is more than rib uptake, or there is no rib uptake at all, then it's 3. So this is, this example we saw was grade 3. So this patient is quite, you can clearly see that the only thing that is shining is the heart. So PYP is a very cheap testing, and I think it has really changed, the way cardiac amyloidosis gets diagnosed. So if it is grade 0, you can rule out the PYP with 99% sensitivity, and 2 and 3, it's 99% specific. So I think grade 1 is the only one that is, kind of in that murky phase. So obviously, we'll talk about my favorite topic, which is cardiac MRI. So, we talked about these patterns. So this is basically the patterns after you inject the gadolinium, right? So once you inject the gadolinium, which is the MRI contrast, the gadolinium can get accumulated in the heart with different types of patterns, right? So you can have subendocardial or transmural, which is ischemic cardiomyopathy. When we think of the amyloid, it's actually very different than any of this, right? So amyloid can lead to like global endocardial, delayed enhancement, but more importantly, on MRI, it's this phenomena of not able to null the myocardium. So basically what we do is once we give the gadolinium, we are trying to, after the gadolinium, we are trying to null that myocardium by applying some sequences. And that is so that if the normal myocardium is all darkened, then you can pick up all the areas of abnormal myocardium, right? So what happens in amyloidosis? Well, unfortunately, there is infiltration of the entire myocardium in a very diffuse pattern. And because of that, you don't have normal myocardium. So however hard you try, you may not be able to null that myocardium. And that should give you the first clue that you may be dealing with a case of amyloidosis. There's this theoretical risk of nephrogenic systemic fibrosis with impaired renal function, which many of these patients have. But again, the latest American College of Radiology guidelines show that the incidence of this nephrogenic fibrosis is quite rare. And most of the hospitals across the world are actually doing cardiac MRI in patients, even with dialysis patient with lower dose and then immediate dialysis, because the risk is such tiny and the benefit may be many folds, particularly when you're confused about the type of which cardiomyopathy you may be dealing with. So again, this is about some of the studies, and so the great positive predictive value, great specificity, and I think I have one more slide on that, so I'll go in that in bit detail. But this is an example of the cardiac amyloidosis, how it leads to different patterns on MRI when it comes to the delayed enhancement. So I guess you probably all forgot how the normal myocardium looks like, but all this should be dark, where you see these, patches, the white patches. So it all should be dark like this, okay? But this is basically inability to null the myocardium. Similarly here, it just all looks fuzzy and bad everywhere, and that is cardiac amyloidosis. This one has subendocardial delayed enhancement. So does this. You can see that there is, you're not able to null, but at the same time, there's some gadolinium concentration around the endocardium. So this is called subendocardial pattern. So you can have that diffuse global subendocardial pattern. So myocardial infarction will lead to subendocardial pattern, but it would be in the region of the artery that you're dealing with, right? So if it is a LAD, MI, then it will be in the anterior anteroseptal wall, right? Versus this is everywhere in the heart. It's like very diffuse all over. So again, LGE is sensitive and specific. These are basically some other different studies that have been done. Again, you can see that you basically presence of LGE is associated with really bad mortality. So you're also able to give, by doing the MRI, you're able to give the patients the prognostic data. So these are the relative numbers, and this is a very useful slide, particularly when you got non-believer in the advanced imaging, right? So, if you look at the low voltage by EKG criteria, look at the sensitivity, specificity, and positive predictive value, poor, okay? Then you look at the Doppler echocardiography, still poor, okay? Then you combine, you get a bit more, but look at the specificity. So only 29% specific. That's pretty bad for anything in medicine, okay? So, again, no patient presents with textbook presentation. We all can identify textbook presentation, but that's not the point. If you want to serve your patient, you should be able to identify the disease in whatever form it presents. And I think that's where you need, more advanced testing, because it's just humanly eyes. It's just not possible to just diagnose, without the testing, unless you go for the myocardial biopsy, which is invasive and it has its own, pitfalls. So quite sensitive and quite specific when it comes to cardiac amyloidosis on MRI. So let's see this example. So this is one of my patients. So again, you can see that, the hypertrophy is there, but, if this patient had hypertension, we would easily say that, well, this is because of, hypertension. But I want to bring your attention, to the RV also. So always pay attention to the RV. So mid myocardial RV hypertrophy will be suggestive of hypertrophic cardiomyopathy, okay? Generalized, just prominence of RVH, along with LVH would be suggestive of amyloidosis, okay? So there are little clues in everywhere that you have to identify. This patient, you can see that it's kind of like inability to null, delayed enhancement everywhere, all these patchy spots. That is because we are unable to null this myocardium. And then we use the latest technological advice in the advance in the cardiac MRI is in form of what we call mapping. So these are different numbers, and for the scope of this talk, we won't be able to go into details, but these are all the abnormal numbers. So ECV more than 25% would be abnormal. ECV stands for extracellular volume. And there's very, very strong data that suggests that these numbers would also be suggestive of the pathology, particularly with combined with other features. So this is the second case. So again, here hypertrophy is a bit more prominent compared to the first case. You can see that it's kind of hypertrophied everywhere, but again, you have to put the patient into context when we are trying. These are the mapping values. Again, increased mapping value. This is what we call the native T1 value, and for our hospital, anything more than 1100 is higher. So this is a higher T1 value. And this is that sequence that we do try to null the myocardium. And you can see that, here, it basically, the entire myocardium, we're just not able to get anywhere, these are a bit complex MRI mechanics probably for the people who don't practice MRI, but I just wanted to show you, since it is often asked on boards, this inability to null on the myocardium, that phrase comes up in the question stem. So remember, that's the concept. We are not able to null the myocardium. We are not able to make it dark completely because the myocardium itself is diffusely bad. So this is in this previous patient, this patient. So when we went to the delayed enhancement, you can see that it's kind of patchy all over, really dirty pictures, and muddy pictures. And that's quite classic of cardiac amyloidosis. So again, one more study showing that positive MRI has a prognostic value. And this is, it's also related with all-cause mortality. So this is a meta-analysis. Mariana Fontana has published a lot, so check out her work on cardiac amyloidosis. Great review papers in Journal of American College of Cardiology by her, and I've learned a lot personally from her, so check out her work. So this is the diagnostic pathway that I offer to you, okay? So obviously echo is the first modality that we all are going to stumble upon, right? So in the echo, this is where you think of pathology, which is LBH, apical sparing on that strain imaging, restrictive cardiomyopathy like picture. Then you do the MRI, and the MRI, you're going to confirm the gadolinium enhancement, pattern, what exactly it is, whether it is subendocardial, whether it is, abnormal gadolinium kinetics, and then you're going to go for PYP. If the PYP is positive, the bone scan is positive, then you're dealing with TTR. Refer the patient to heart failure clinic, get the patient started on tafamidis. If the PYP is negative and you have other comorbidities like multiple myeloma, or if you have light chain ratio that is positive, then it's a likely AL, and then refer the patient to heart failure clinic. So I think I'm gonna quickly skip. So biomarkers like these showed that these patients would often have the troponin as well as the BNP that is, positive, and both of these biomarkers actually, indicate indicates a prognostic value. And real quick on the blood test for the AL amyloidosis, your test of choice is the serum light chain ratio. Okay. So this is the one test. If you want to order one test, that's what I would order. If you can order other tests, then you can probably order, these 5 tests, which is immunofluorescence, protein electrophoresis, serum light chain ratio, and then combine all of them, and you have higher sensitivity and specificity. One word about the biopsy. So bone marrow, rectal, or fat pad biopsy is less invasive, but unfortunately the sensitivity, the ability to rule out the negative testing suffers. Heart is most sensitive for cardiac amyloidosis, and it has 100% sensitivity, but it is invasive and has been associated with some risk, as you all know. So I think that we have enough with the non-invasive that most of the times, for TTR at least, we don't go for biopsy or anything. So your take-home point, so that we get some time for questions, is not all amyloid is the same, okay? These patients can have thrombus, so do not cardiovert without a TEE. Normal voltage or LVH on EKG does not exclude the diagnosis of cardiac amyloidosis. Delayed diagnosis is the worst prognosis. And diagnosis, in my humble opinion, start with the non-invasive testing, starts with the MRI and goes to PYP to differentiate between the 2 types so that you can start the patient on correct treatment. So coming back to our case that I initially presented, so this patient had really high serum free light chain ratio. both lambda and kappa, and the kidney biopsy was suggestive of AL amyloidosis. I also underwent bone marrow biopsy. Unfortunately, had diagnosis of multiple myeloma. Cardiac manifestation was how this presented, unfortunately. And she was discharged on Lasix, and she will receive this chemotherapy. I think since there's so much about politics going on, I just wanted to put this. So, you know, if you wanna, the success in the election is vote early and vote and often. It's the only way to beat the other side, right? And I would say that for cardiac amyloidosis, think of it early and think of it often, and that's the only way to beat this disease. So with that, I will stop talking and take any questions. Let's see.
Thank you so much for the excellent presentation, Dr. Parwani. We really appreciate your time to come out here today. Unfortunately, Dr. Rahani had to leave us, but she wanted to congratulate you on your excellent presentation. So thank you very much.
Thank you, Ellie.
And if you would like, I could read out the questions. If not, you're more than welcome to answer them yourself. So whatever you want best.
Yeah, I can see them. So Aditi is asking, is there a way to differentiate between AL amyloidosis causing NSTEMI and NSTEMI due to atherosclerosis, and is the management different? So I think the question is the patient presenting the first time to you with NSTEMI, right? So if someone is presenting the first time with NSTEMI, and if the NSTEMI is big, you know, where you have quite a bit of troponin elevation, you're gonna have to take the patient for cardiac catheterization. And that's the only way to differentiate. But what I meant to say is most of the time these patients have tiny troponin elevation. In those cases, we don't take them for cardiac catheterization because it's explained by the heart failure. But I think that if you have troponin elevation that's substantial, there is no other way to diagnose it other than doing the cardiac catheterization or some sort of anatomical testing. Let's see. Great talk. A question. ICDs are known to help in the patients with advanced heart failure. Why would they not help? So as I said, so in these patients, the sudden cardiac death do not happen due to ventricular tachycardia. It happens due to electrical mechanical desynchrony. So ICD, help the patients. And remember, this is restrictive cardiomyopathy or cardiac amyloidosis. This is heart failure with preserved EF. So you don't meet the ICD criteria by EF, because rarely these patients have, very advanced diseases when they would have less than, 35% ejection fraction. But most of the cardiac amyloidosis is actually preserved EF. So they have their EF, 45, 50%. Somehow you do have heart failure. So you don't meet the criteria of the ICD by ejection fraction. And because of the reason why sudden cardiac death in these patients is not mediated by ventricular tachycardia, and that's why the ICDs are not that helpful in this population. What is the reason apical strain is spared? So apical strain, apex is spared from the strain. That's probably what you meant. And the reason being is the deposition starts in the base, and it just goes from base to apex. And there is actually a criteria, a paper that came out in, at least it's in MRI literature, where you can kind of see the involvement from the base to apex and calculate a score. So base gets involved first with the tissue deposition, and hence the apex is spared, and that's why you see that pattern. Great presentation. Amyloidosis is one of the reasons. How common causes are sarcoidosis, hemochromatosis, etc., causing restrictive cardiomyopathy. I think that's a great question, and that's why I started with, I think that sarcoidosis to me more causes dilated cardiomyopathy, and manifestation tends to be different. I don't think that sarcoidosis causes high percentage of restrictive cardiomyopathy. Hemochromatosis is, it can, another reason, but in clinical practice, what we see mostly is amyloidosis. And I think since we had limited time, I wanted to focus on the most high yield topic. And okay, so that is all for the questions. Since if no one has any other questions.
Hi, Dr. Parwani.
Hi, Jose. How are you?
Congratulations on your excellent presentation.
Thank you.
Now, we just want to see if the chapter from Cameron that's watching us live wants to do a question live, okay?
Yeah, sure.
So, Alfred, if you want to do any questions, feel free to unmute yourself. Well, if they don't have any questions, I have one myself.
Sure.
I wanted to ask you if you, in your experience, you could accurately differentiate a cardiac amyloidosis from other restrictive cardiomyopathies with MRI.
Other restrictive cardiomyopathy, I'll tell you that I have rarely seen other restrictive cardiomyopathy. I think the other one that we most commonly see, it's because of the hypertensive heart disease. Hypertension can lead to that. And, in cardiac MRI, I mean, your features would be completely different when you have hypertensive heart disease. Most of the times, the presentation and everything is just so classic that you would know. So I think most of the times the hypertensive heart disease won't give you all that pattern with delayed enhancement and, the inability to null and everything that I was showing.
Okay. I think the Cameron chapter wants to make some questions.
Sure.
See. Alfred, do you want to make any questions?
Yes, thank you, Dr. Parwani, for your great presentation. Our video is not so clear. Thank you very much.
No worries. Yeah, thank you for joining.
Okay, I just wanted to find out quickly, implantable cardioverter defibrillators do help in a certain way in patients with advanced heart failure, but you specifically mentioned that in patients with amyloidosis it doesn't help. Is there a reason for that?
Yeah. So I think I answered that, but I'll answer it again. So basically, as I was saying earlier, that these patients are, they have preserved ejection fraction. So their ejection fraction is not low. And most of the times in heart failure, the ICD indication is for low ejection fraction, which is less than 35%. And so they don't meet criteria for ICD by the EF. And why, pathophysiologically, why it doesn't help is because VT is not the driving reason how these patients die. VT is rare in these patients. It's it's basically the electromechanical desynchrony. They don't have much cardiac output, and that's why, they die. That's the most common reason. And hence ICD with the preserved ejection fraction, it's not that helpful.
Thank you very much.
Thank you.
Well, thank you very much, Dr. Parwani, for your excellent presentation. I particularly enjoyed both of them.
Thank you. Thank you so much for inviting me.
And thank you everyone else for joining us. I hope to see you next time. It was a pleasure.
Thank you, Rodriguez. Thank you very much.
Bye-bye.
Bye.